Welcome back to KMR Advice for another deep dive. Today, we're tackling a really crucial topic for all of you future medical professionals, the ins and outs of cardiac glycosides.
That's right.
Specifically, we're focusing on digoxin and also looking at the broader world of medications used to manage heart failure.
Exactly. Think of this as your dedicated study session. We're pulling directly from essential knowledge in drugs for heart failure, digoxin and beyond.
Right. Our goal today is to get a really solid understanding of digoxin's role, how it's used in heart failure, atrial fibrillation.
We'll dissect how it works, navigate its potential challenges, and see where it fits in the bigger picture of treatments. So let's dive in.
And as always, if you find this helpful here on KMR Advise, please do share it with your colleagues, subscribe, and definitely hit that bell icon for more medical insights.
Please do.
Okay, let's unpack this. Starting with, how is digoxin actually used? Our source highlights a few key areas. First up is congestive heart failure, or CHF.
Right. In CHF, digoxin is mainly used to help manage symptoms. It can be particularly useful in patients who have heart failure and also atrial fibrillation, that common irregular rhythm.
Okay, so it's not necessarily the first thing you reach for all CHF patients.
Exactly. It's more about making patients feel better, symptom relief, especially when that fast, sort of chaotic heartbeat of AFib is also going on.
Right.
Which, speaking of which, that's the second big use for digoxin.
Atrial fibrillation and flutter, what's its role there?
So in these arrhythmias, digoxin helps slow down the ventricular rate. That's, how fast the bottom chambers of the heart are beating.
Okay.
Now, a really key thing to remember here is that digoxin doesn't actually convert the rhythm back to normal. It just helps keep the speed under control.
That's a super important distinction. Okay. The source also mentions a less common use, paroxysmal supraventricular tachycardia.
Yes, that's a more specialized application, usually considered only in very specific cases of that particular rapid heart rhythm, not a primary use.
Gotcha. Moving on, the text then helps us sort of organize these drugs by classifying them. It separates cardiac glycosides, like digoxin, from non-glycoside inotropes. What's the basic difference?
Well, the core difference is in their chemical structure and how they actually work. Digoxin is really the main cardiac glycoside we see used today.
Okay.
The non-glycoside inotropes, things like dobutamine and milrinone, those are generally kept for more acute or severe heart failure situations when you need a more immediate and powerful boost to the heart muscle's contraction.
Right, like in the ICU, maybe?
Often, yes. And the classification also mentions other HF drugs, which I guess we'll explore later to see the whole picture.
Absolutely. That's a broader category. Includes many of the more modern cornerstone therapies for heart failure.
Right.
Now, let's dive into some really key points about digoxin itself from the keynote section. First one is positive inotropy. Simple terms, what's happening?
Okay, let's break it down. Positive inotropy just means digoxin increases the force of the heart muscle's squeeze. Think of it as giving a weaker heart a bit more, oomph with each beat. This can be really helpful in a failing heart that's struggling to pump blood effectively.
Makes sense. And the second keynote, negative chronotropy. How does that help?
Negative chronotropy means it slows the heart rate down. It does this mainly by increasing the activity of the vagus nerve.
Ah, the vagal tone.
Exactly. That has a calming effect on the heart's pacemaker, the SA node, and it also slows down how fast signals travel through the AV node, the sort of gatekeeper between the top and bottom chambers.
Now, this next point seems critical. The narrow therapeutic index. What does that actually mean for clinical practice? This is vital for our KMR Advise viewers, especially future prescribers.
Absolutely critical, yeah. A narrow therapeutic index means there's a very, very fine line between a dose that helps and a dose that's, frankly, toxic. For digoxin, that index is only about 1.5 to 3. So, sadly, toxicity can happen relatively easily.
Wow.
It really hammers home how vital it is to be meticulous with dosing, monitor patients closely, and understand all the things that can affect digoxin levels.
That sounds like walking a tightrope, really.
It can be.
And the last keynote here is that digoxin only provides symptomatic relief in CHF. It doesn't change the underlying heart structure, the remodeling. Why does that distinction matter so much?
Yeah, this is fundamental. While digoxin can make patients feel better pumping controlled heart rate, it doesn't fix the actual structural damage that happens in heart failure.
Okay.
So think of it like it helps the heart work better despite the damage, but it doesn't repair the damage itself. That's why it's often used alongside other meds that do target remodeling and aim for better long-term outcomes.
So it improves how someone feels day to day, but doesn't necessarily extend their life directly in heart failure itself.
Precisely. That's a key takeaway.
Okay, let's move to the mechanism of action, the MOA. The source breaks this into steps. Step 1, receptor interaction. How does digoxin actually start working at the cell level?
Okay, so at its core, digoxin works by blocking an enzyme. It's called the sodium-potassium ATPase pump, right on the surface of heart muscle cells, the myocytes.
The sodium pump.
Yeah. Think of it like a little shuttle bus, constantly moving sodium out and potassium in. When digoxin blocks this pump, sodium starts to build up inside the heart cell.
Okay, more sodium inside, then what?
This extra intracellular sodium then messes with another transporter, the sodium-calcium exchanger.
Right.
Normally, this exchanger swaps sodium going out for calcium coming in. But with all that sodium already inside, the exchange slows down. Less calcium leaves the cell.
Ah, so more calcium stays inside.
Exactly.
Right.
And as you know, calcium is the key trigger for muscle contraction. So this extra calcium leads to a stronger heartbeat. That's the positive inotropic effect we mentioned, a temporary strength boost.
Got it. Blocking the sodium pump indirectly boosts calcium, making the heart squeeze harder. The source also mentions a vagomimetic effect. What's that?
Vagomimetic just means it mimics the effects of the vagus nerve. Remember the negative chronotropy, slowing the heart rate.
Yeah.
Well, digoxin enhances that vagal activity, which further slows down the electrical signals in the heart, especially at the SA and AV nodes.
Okay, so that covers step 1, the receptor part. Step 2 is clinical effects. How do these cellular changes translate to what we actually see in a patient?
Well, the stronger contraction means the heart pumps more blood per beat. That's increased cardiac output, which is obviously good for a failing heart.
Right.
The slower heart rate, bradycardia, reduces the heart's workload. And in patients with AFib, digoxin's effect on the AV node helps control how many of those fast, chaotic signals get through to the ventricles. So it controls the ventricular rate.
That ties it all together nicely. And step 3 is termination. How does the body get rid of digoxin?
It's primarily cleared by the kidneys, renal excretion,
Okay.
which is why, as we sort of touched on, it's so critical to adjust the dose in patients with kidney problems to prevent it building up to toxic levels.
Yeah, that links straight back to that narrow therapeutic index again, doesn't it?
Absolutely. They're directly connected.
Let's look into pharmacokinetics now. This section gives us some numbers. Oral absorption, 60 to 80%. Practical takeaway.
It tells us a good chunk gets into the bloodstream when taken by mouth, but not all of it. So that bioavailability, needs to be considered when dosing.
Plasma protein binding is about 25%. What does that mean?
Means about a quarter of the digoxin in the blood is stuck to proteins. The rest is free to act on the heart and be cleared by the kidneys. It's not super high binding, so drug interactions based on bumping drugs off proteins aren't a huge concern compared to some other meds.
Okay. The half-life is around 40 hours. That seems quite long.
It is, yeah. Relatively long. It means it takes a fair while for the body to clear half the drug.
Right.
This affects how long it takes to reach a steady state when starting it and how long it takes to wash out if stopped. Dose changes won't show their full effect immediately.
And cleared mainly by the kidneys, as we said. The therapeutic range, in 0.5 to 1.4 NE/gmL. Why is staying in this window so critical? Another key point for our KMR-advised viewers.
Monitoring levels in this range is absolutely vital because it helps us find that sweet spot, a dose that's likely effective for symptoms without being toxic, given that narrow index. Levels below might not work well enough. Levels above significantly hike the toxicity risk. But it's important to remember, we treat the patient not just the number. The ideal target might vary a bit.
Right. Clinical context is key. And finally, typical maintenance dose, 0.125 to 0.25 milligrams per day. Is this the usual starting range?
Exactly. That's a common starting point. But the actual dose is always tailored based on age, weight, kidney function, other meds, other conditions, all of it.
Okay. Now for a really important section, adverse effects and toxicity. The source reminds us again, low margin of safety. Let's start with extra cardiac effects outside the heart.
Right. These can be quite varied. Common ones are things like loss of appetite, anorexia, nausea, vomiting, which can sometimes be mistaken for, just feeling unwell.
Yeah, non-specific.
Exactly. A classic, really distinctive sign, though, is visual changes, often described as seeing things with a yellow tinge or yellow halos around lights.
Xanthopsia.
That's the one. Patients might also get confused, feel really fatigued.
Those sound unpleasant and could definitely impact quality of life. What about the cardiac effects, the ones on the heart itself?
These are particularly concerning, obviously. Basically, Any kind of arrhythmia is possible with digoxin toxicity.
Any kind. Wow.
Yeah. PVCs, ventricular tachycardia or VT,
Uh,
AV block where signals get slowed or stopped, severe bradycardia, even patterns like bigeminy where every other beat is abnormal. It just highlights how crucial it is to recognize these signs.
it's quite scary that a heart drug can cause such serious heart rhythm issues. What's the treatment of toxicity? What do we do?
First and most important, stop the digoxin immediately.
Right.
Then, depending on severity, we have other tools. If potassium is low, correct it, because low potassium makes toxicity much worse. Conversely, high potassium also needs careful management. For dangerous ventricular rhythms, maybe use lidocaine. For severe bradycardia or AV block, atropine might help speed things up.
And I remember reading about digoxin-specific antibodies, Digibind or Digifab.
Yes, the Fab fragments. These are basically antibodies designed to grab onto digoxin in the blood and neutralize it. Really important, sometimes life-saving, for severe toxicity.
And finally, the source says avoid DC shock if possible during toxicity. Why?
Yeah, DC cardioversion using an electrical shock for rhythm problems carries a pretty high risk of causing a systole, a complete flatline, in patients with digoxin toxicity. So we generally avoid it unless absolutely necessary, and even then with extreme caution.
Okay, moving to precautions and contraindications. First is hypokalemia, low potassium. We mentioned it with toxicity, but why is it a general precaution?
Well, as we said, low potassium dramatically increases the risk of digoxin toxicity, so we always need to be mindful of it.
Right.
Especially important in patients also on diuretics, because many diuretics make you lose potassium. Unless you're replacing potassium, using those diuretics with digoxin needs really careful potassium monitoring.
What about patients with kidney or liver issues or older adults?
In patients with impaired kidney function, and to some extent liver function, and also in the elderly, the body might clear digoxin more slowly.
Okay.
This leads to higher drug levels, greater risk of toxicity. So often need lower doses in these groups, as we discussed with pharmacokinetics.
The source also lists some conditions where digoxin should generally be avoided. Myocardial ischemia, myocarditis, WPW syndrome, VT. Why these?
Okay, so in ischemia, reduced blood flow, or myocarditis, heart inflammation, digoxin's effect of increasing contraction force could potentially worsen things or raise arrhythmia risk.
I see.
In Wolff-Parkinson-White syndrome, that extra electrical pathway, digoxin can paradoxically speed up conduction down that pathway during AFib, leading to a dangerously fast ventricular rate.
Oh.
And if someone's already in ventricular tachycardia, digoxin is generally a no-go, as it could destabilize the rhythm further.
Lastly in this section, drug interactions. Several are listed that can increase digoxin toxicity risk.
Yes, quite a few meds can raise digoxin levels, diuretics, mainly by causing low potassium, but also drugs like quinidine, verapamil, and amiodarone can interfere with how digoxin is handled and eliminated by the body.
And some can decrease digoxin absorption.
That's right. Things like antacids, neomycins, sucralfate can bind digoxin in the gut, potentially making it less effective. It's just vital, and we always stress this on KMR advice, to know all the medications a patient is taking to avoid these interactions.
Absolutely. Now, circling back to clinical uses, it's mentioned again for congestive heart failure. Main points to remember.
Key thing to reiterate, symptom relief, especially in systolic dysfunction, weak pump with rapid AFib. But remember, it's not disease-modifying, doesn't fix the underlying problem, or improve survival in CHF itself.
And for atrial fibrillation flutter, its practical role.
Primarily rate control. Slowing down how fast the ventricles beat doesn't convert the rhythm. It might be preferred in less active patients and sometimes used with beta blockers or calcium channel blockers if needed for better rate control.
Okay. The source then broadens out to drugs for heart failure beyond digoxin, dividing them into symptom relief versus disease modification survival benefit. Let's start with symptom relief.
Yeah, for quick relief, especially in acute or severe HF, we use diuretics like furosemide, thiazide, spironolactone to shed excess fluid.
Right.
Vasodilators like nitrates, hydrolazine, nitroprusside, widen blood vessels to reduce heart strain, and inotropes like dobutamine, dopamine, milrinone give a stronger pump in urgent situations.
And then the really crucial category, drugs offering disease modification and improving survival.
This is where the big advances have been.
Yeah.
Mainstays are ACE inhibitors or ARBs, beneficial for most unless contraindicated.
Foundational therapy.
Absolutely. Beta blockers like metoprolol, bisoprolol, carvedilol also cut mortality, but crucially started after the patient is stable. And aldosterone antagonists like spironolactone, eplerenone, shows survival benefits in specific groups, too. It's so important for the KMR Advise audience to grasp that these are the long-term management cornerstones, quite different from digoxin's symptomatic role.
The source also briefly mentions non-pharmacological measures.
Yes, lifestyle stuff is key. Rest when needed, strict salt restriction to minimize fluid buildup. And critically, finding and treating any underlying causes, high blood pressure, valve issues, arrhythmias, anemia, thyroid problems.
Makes sense. There's a useful summary table, drugs and heart failure, bringing it all together.
Absolutely. It's a great quick reference. Shows diuretics help symptoms, but not survival. ACE inhibitors, ARBs, and beta blockers do both. Digoxin for symptoms and AFib rate control, no survival benefit. It's really helpful for review, especially for medical students watching KMR Advise.
The source then gives a clinical case application outlining a general approach for an older man with CHF.
Yeah, it shows how you might sequence things. Start with non-drug measures like rest, salt restriction. Then initiate an ACE inhibitor and a diuretic. Then consider adding digoxin for symptoms if needed. Then carefully titrate up the ACE inhibitor, and finally add a beta blocker once stable. It puts the principles into a practical flow.
And always helpful for students, key mnemonics. The one for digoxin toxicity is dangerous. Can you walk us through it?
Sure. Dangerous. D for diarrhea, A for arrhythmias, N for nausea, G for GI upset generally, E for ectopic beats, R for restlessness or confusion, O for ocular changes, that yellow vision, U for unconsciousness in severe cases, and S for slow pulse bradycardia. Handy way to remember the key features.
That is useful. Finally, a more detailed clinical case application focusing on Mr. Ramesh. Let's go through his presentation and the suggested plan.
Okay, Mr. Ramesh, 72 years old, comes in with worsening shortness of breath, orthopnea, needing to sit up to breathe at night, leg swelling, fatigue, can't exercise much, history of hypertension, previous heart attack, admits he's not been great at taking his BP meds.
And the exam findings.
Mildly distressed appearance, pitting edema in the legs, raised GVP in the neck, apex beat displaced, heard an S3 gallop, crackles in the lung bases, slightly enlarged liver. Vitals, BP a bit low, heart rate 88, breathing a bit fast at 22, O2 set 94% on room air. Classic signs of fluid overload and heart failure.
And the investigations confirmed things.
Yes, ECG showed the old MI, sinus rhythm, echo was key, LVEF only 32%. That's significantly reduced pump function.
Wow.
Also dilated left ventricle, mild mitral regurgitation. Blood showed creatinine 1.1, potassium 4.3, and a high BNP level, all fitting with heart failure.
So the diagnosis: chronic heart failure with reduced ejection fraction, HFrEF, NYHA class 3, significant limitations. Let's break down the management plan from the source, starting with non-pharmacological measures.
Right. Initial steps: bed rest until stable, low salt diet less than 2 Bringue, maybe fluid restriction if needed. Daily weights are crucial. And huge emphasis on patient education. Meds, diet, symptom monitoring.
Then the pharmacological therapy, step by step. Step 1, start an ACE inhibitor and Alprol.
Yes. Start low, 2.5 milligrams twice daily. Titrate up as tolerated. Rationale: survival benefit, reduces workload, prevents negative remodeling. Foundational.
So 2, start a loop diuretic, furosemide.
Yep, 20-40 milligrams daily, adjust based on fluid status. Main goal here is rapid symptom relief, get that fluid off, help the breathing and swelling.
Step 3, consider adding digoxin. What's the thinking here for Mr. Ramesh?
Might consider digoxin, maybe 0.125 or 0.25 milligrams daily, adjusted for kidney function and age, if you remain significantly symptomatic despite the enalapril and furosemide.
Okay.
Or if you developed AFib. The goal would be further symptom improvement, but again, remembering it's for symptoms, not survival.
Step 4, titrate the ACE inhibitor, enalapril.
Exactly. Gradually increase the dose every 1-2 weeks, watching blood pressure, kidney function, potassium. Aim for the highest tolerated dose for maximum benefit.
Step 5, add a beta blocker, midoprolol succinate.
Start low. 12.5-25 milligrams once daily, increase slowly over weeks. Crucially, only start after he's stable, not acutely decompensated. Rationale: beta blockers also improve survival, prevent arrhythmias, improve LV function long-term. Another cornerstone therapy.
And step 6, consider an aldosterone antagonist, spironolactone.
Might add spironolactone if symptoms persist despite ACEI, beta blocker, diuretic, and if his LVEF is low and kidney function, potassium are okay.
Okay.
Rationale: added survival benefit in specific HFrEF populations. Requires close monitoring of potassium and kidney function, though.
The plan also lists follow-up and monitoring. Key things to watch.
Regular checks of kidney function, electrolytes, especially potassium, BP, heart rate, symptoms, assess medication adherence, check for side effects, Watch for digoxin toxicity signs if he's on it. Also, keep vaccinations like flu and pneumonia up to date.
There's also that summary table of therapy, recapping everything, and the rationale for each step reinforces the thinking. Finally, some really important exam pearls. Key takeaways for KMR-advised viewers.
Yeah, the high-yield points. Digoxin is for symptoms, doesn't improve survival in HF. Never start a beta blocker in acute decompensation. Always watch for digoxin toxicity, especially in elderly renal impairment. And always, always look for and treat underlying causes of the heart failure.
So to wrap up our deep dive today, we've really covered digoxin from multiple angles, haven't we? Its role in heart failure and AFib, its mechanism, that critical narrow therapeutic window, and why careful monitoring is just non-negotiable.
Absolutely.
We've also placed it in context with other heart failure drugs, highlighting that vital difference between symptom relief, like digoxin offers, and the disease-modifying drugs that improve survival.
Exactly, and Mr. Ramesh's case illustrated that well. Digoxin might have a role for his symptoms, but it's part of a bigger strategy focused on those foundational ACE inhibitors and beta blockers.
So for all of you tuning in on KMR Advice, think about Mr. Ramesh. How would the principles we discussed guide his ongoing care? What would you be most vigilant about? How would you track his response?
And that leads to a final thought. Heart failure treatment is constantly evolving. New research brings new therapies beyond drugs like digoxin. Staying informed about these advancements is essential for good clinical practice.
Absolutely. Well, thank you for joining us for this in-depth look at digoxin and heart failure drugs. Please share this with your colleagues. Subscribe to KMR Advice for more deep dives like this, and hit that notification bell.
Definitely. Keep learning.
Until our next deep dive, keep learning and stay curious.